We want to greet you from the Inter-American Conference of the Social Security Center and also from the Study Center. Dr. Daisy Corrales Diaz. I am joined by Dr. Daniel Manginelli, who is our main researcher in the area of health and well-being from the Inter-American Commission Conference, and Dr. Dorothy Bravo, who is the director of research. Today, we have the pleasure of continuing with our training activities in a different order for sustainability for healthcare systems, their challenges, their important challenges, and thus being able to converse with two experts in the field who will give us important knowledge and especially a reflection space regarding sustainability. When we talk about sustainability, oftentimes we mean the financial area. However, we need to acknowledge that in order to achieve sustainability in healthcare services, we all have an important role, users, with the correct utilization of services from the institutional areas regarding planification in terms of having policies in risk management, and that way touching every corner of sustainability from a situation that is not just regarding institutions, but with the participation of every stakeholder that partakes the head of the institutions in social security, as is the case of our institutions in our country. We have a three-party functioning, and we see topics about companies, labor, with all of the representation for the workers, and also the representation of state, where they have an important role in sustainability. For that reason, we have two very experienced guests who will be introduced from here. They have a very comprehensive curriculum, but I would like to greet Dr. Rosa Cristina Laurel, who is the director of the institutional transition for the Mexican Institute for Social Security. She is working at a very important role in terms of what the current organization is. And she has a great experience in different countries, working at different or international organisms. She is a global authority in terms of social security, and we want to thank her for her presence here because we know that she is a very busy person, but she's always willing and very generous with channeling and transmitting her knowledge. And Professor Picado, who is the financial manager for the Costa Rican Chamber of Social Security, who is also joining us today, and he has developed his experience growing within the institution and always achieving with a great willfulness the best way to take advantage of all the resources. So I leave you with Dr. Daniel Mantinelli. He is our research leader for the Inter-American Healthcare and Well-Being Commission. He has a professor's degree in research, and he also does he has experience in CONACYT and also publications from migrations, other topics on health, and he is functioning with us with a very important work plan that has been created from the needs in our country here of our country members here in the conference. There are some statute levels in the organization through levels. They have a directive board where we get most of the proposals because of the needs of the region. And we have also American conferences in social security regarding the different topics generated in the General Assembly for this conference as priority issues. So with that in mind, I give the floor to Dr. Mantinelli. Thank you, Doctor. Good morning, everyone. I am Dr. Daniel Mancinelli, and I am the coordinator for this webinar titled conversation or discussion table on the functionality of healthcare systems, functionings, and perspectives. It is developed by the Inter-American Center of Studies in the CS from the Inter-American Conference on Social Security, or CIST. The objective of this webinar is to have experts talk about different topics, such as the challenges of financial sustainability prior and during the pandemic of COVID-19, the financing strategies implemented thus far, and the projections for the future mid and long term. And that corresponds to a very specific context. According to the WHO, a financial institution in healthcare systems means that there is enough economic funds collected in order to organize the usage of healthcare services and also offering protection before different risks and catastrophes. In that sense, sustainability guarantees compliance with the right to healthcare. In Latin America and the Caribbean, healthcare institutions have faced a series of challenges that refer to the increase in the cost of technological innovation, the increase of demand in healthcare services, limited healthcare budgets, and different limitations regarding the GDP in each country, the fragmentation of healthcare systems, inadequate use of resources, and weak prevention programs. Also, they have faced a series of challenges as well, including weak government finances, different levels of informality, the implementation of different social programs, and also transitions of population regarding the pandemic and stuff. So also the different sanitary conditions during 2020 and 2021. So facing that scenario, we open this discussion table, this dialogue space, to observe the different perspectives by expert Dr. Asa and expert Dr. Gustavo. So I'm going to start by introducing our first speaker. I want to thank the presence of Dr. Asa Cristina Laurel, who is a doctor by the Lund University in Sweden, public health by the University of California in sociology, and Dr. honoris causa by the University of Buenos Aires, Argentina. She was the head of the institutional programs from UAM Xochimilco from 2017 to 1997 to 2000. She also worked as the Secretariat of Government from 2000 to 2006, where she implemented the universal pension for elder people and the service for free access to medications. From 2006 to 2012, she worked as a director as well as center, and she has authored over 100 magazine articles and specialized books in topics of healthcare and well-being. She has been also an advisor for the WHO and also for the different topics for social security in different legislations. She was also an independent consultant from 2013 to 2018 and advised as well Mr. Andrés Manuel López Obrador and under secretary for the government of Mexico from 2008 to 2020. And she's currently the planning director for the institutional transformation from the Mexican Institute of Social Security as of October 23rd, 2020 to this day. I would like to also welcome Mr. Gustavo Chacon, and he is from the University of Costa Rica with a specialization of capitals and actuarial techniques for Social Security. He is the author and co-author of different studies and reports also regarding topics such as social protection, Social Security, healthcare, social systems, financing to social systems and healthcare systems, pensions, pension programs, strategies and mechanisms for contributional and non-contributional areas in social security, and among other topics. He is currently the financial manager for the Costa Rican um, mailbox for the healthcare system in Costa Rica, and he has also worked as a administrative manager, director of human resources, pensions director, administrative director from the pensions sector, and also the chief of economic research from the actuarial division. Now I'm going to mention what this dynamic is about. So we will have 4 questions. First, one where we are going to give the floor to Dr. Asa and then Professor Gustavo so that they can give us their point of view regarding that question specifically. We do not have a set amount of time for that response, so you can take as much as you consider necessary to respond. So the first question is, what have been the historic challenges and difficulties for the financial sustainability in healthcare systems, according to your great expertise? Well, good morning. Thank you very much for the invitation. Greetings to everyone in this great conference. So I believe that in the light of this dynamic, the idea is for it to be a conversation or a discussion table. So we would leave a very specific and concrete answer to the question so that then we can converse or discuss with the audience as well in order to see how we can do this exercise. So the first thing I would like to answer this question with is that budget is always an expression of a government's priorities. And I say that because it's not like there is a single answer regarding how we can distribute the different budgets for a state or a government. But it depends on the priorities of this government and what they place as least important. So I think in the case of Mexico, where we share priorities with different Latin American countries, at least for the past few decades, is that what has been predominantly important in the neoclassical period in terms of economy, which we know more like neoliberalism or economic neoliberalism, is that there has been very little importance given to social protection in general terms. So, health, even education, pensions, etc., have not had much presence. And that is expressed, among other things, in the fact that budgets budgets that are allocated to health in the past few decades in Mexico, we can say after the beginning of the 80s, where they fostered or imposed the neoclassical economic model, it has represented barely a 3% of the public budget. So over here, I would like to talk or direct our attention towards the fact that there is an incorrect way, in my perspective, to talk about healthcare budgets when we differ between public and private sectors. It varies to up to 6% of the GDP. And the private sector is not directed towards the set of population. It's a budget that spends for those who can spend, actually. And it's done in a way where, and actually I'm going to adhere to the public budget in terms of healthcare so that we are clear what we're talking about. So the second point I wanted to underline is that there is a trend towards the growth in the healthcare sector as a private finance sector has increased the per capita cost for medical attention, and it has decreased the allocation of budgets towards the education, promotion, and prevention in healthcare topics. So the way that this is distributed has grown in everything regarding the technological development, both in terms of equipment and also the healthcare consumables. So, what it means is that investment in healthcare education, prevention, promotion of health has decreased proportionally. Of course, that depends on the fact that the development areas, both for healthcare equipment and medications and vaccination, has advanced generally within the private sector, so that production is for profit. And that has meant a very important growth in the healthcare expenses. Actually, we can even say that after that, there are organisms inside the government to supervise, mainly on two issues. So on one side, we have this innovative invention and how it can be compared to other equipments or medications that have the same function. So there is this blockage to government in terms of commercialization in healthcare terms. So I would say that to begin with. Thank you very much. Professor Gustavo, you have the floor. Thank you very much. Good morning, everyone. Thank you for the invitation. It's a pleasure to share this activity with you. And now, regarding the initial question, I absolutely agree with Dr. Cristina Laurel in her ideas, her basic ideas. One is that indeed the allocated resources for healthcare systems reflect the priorities for governments and societies. That is without a doubt. Then the other part is we have this uh, economic conundrum where we are facing, and it has to do with the resources that are very limited versus unlimited needs. And then the other part is that I think, of course, that there's a series of elements that have placed financial sustainability in terms of healthcare systems in a different in different dilemmas, say for financing especially. And so in general we can find that for the region the financing levels are suboptimal to what is required at a certain point. The PAHO has said that there is an interesting point. They have approved empirically those countries that reach the goal have better results, and then not necessarily other countries that are below that 6% cannot obtain uh, results that are as good as the other ones. And then we have a some countries that spend over 17%, and they can get a better benefit than those that are spending less than that. So from the perspective of challenges and difficulties that we see in sustainability, there are very specific points. One are the design limitations for that financing model, which of course are structured, and there's no way to reach the optimal levels that are expected. And then internally in that design, there are definitions such as who is giving an input, how much they give, what's the degree of solidarity for that system, what's the role of the state, and how much they are abiding by their role of financing, and what's the fiscal input of different sources of financing. And then there's another element in that in the region we have faced a lot. There are fragmented and segmented systems, and that, of course, erodes the financing capacities. Of course, there are different areas where we have tax and entities that duplicate, and then we cannot really concrete the expected levels of sustainability and economy. And then we hope that the financing of the healthcare system is one, but then healthcare does not depend just on the healthcare services, but also what we find as difficulties is that the primary financing for healthcare systems should always accompany the supplementary areas in different areas like electrification, housing, basic education, attention to the different levels of poverty faced in different countries. And at the end of the day, that's important to allocate a 6% or more of that budget to those activities. But other, not just that, but also other activities that have a different effect on the resources themselves. So also in different countries, we could say that these complementary investments have even a better impact that than the healthcare system. And then the other elements are quality and expense efficiency. So it's not important just to take care, or it's important not just to take care of a certain level of financing, but also I would say it is a lot more important to decide which activities and what levels of attention will get distributed as a priority. So then the financing that we have is targeted to activities that are about hospital and healing, and they have a high to medium need versus the first level of attention where we have a bigger cost effectiveness in that investment. So it's not just a matter of the level of financing, but also the quality and efficiency of that expense and where we allocate that prioritarily. Of course, we are also facing, as the time goes by, a sustained momentum in the increase of healthcare expenses. And I would say that in general, we all understand that the cost for services or the different healthcare attentions has grown in the past few decades, but that doesn't mean that it will happen in the future. So there's no reason to think that the results for the diseases in people, individuals, and collectives tend to increase for known reason, like aging, the epidemiological profile changes, high cost medications, ever evolving technologies, and the different matters that we can consider when talking about the costs. So at the long term, we have not reached enough level of financing in healthcare systems, and what we have left is to sort out the next step, because we will have a sustained momentum of costs as we have seen in the past few decades. And there is a private sector. From my perspective, I'm not saying that this is from all countries, but it's not controlled. And the private sector, whether it be out of your pocket or in a different purse or any other insuring instrument, they usually have a low effectiveness because they address different situations that are more focused on healing, and there are no approaches on activities that could actually yield a more robust health in people through activities and attention at the first level, especially for healthcare promotion. And actually, there is this expense that general administration is very shallow. The administrations do not act strongly enough. And in general, at least in Costa Rica, we see that the private sector expense goes back to our institution, which is the Social Security, and then we need to reapply diagnostics and tests. And so, from my perspective, the private sector is this focus to make the system, because at the end of the day, the private sector is part of the system, and we need to take that to make that more efficient. And then at the beginning, Dr. Corrales was mentioning this, that the systems have not had enough of an impact in self-managing the health of people or by people. And then we find indicators where there's a difference between the habit or the lack of habits and healthy practices. So we have a moving target, which is people, individuals, and collectives, and then we can see more that people, if there's a trend to have more activity and other healthy activities, we see obesity rates or weight increase, which is very harmful for the region. So, in that matter, the challenge of sustainability is a first line challenge. And also, it depends on the design of the healthcare system in each country, and also the collectives that we have and the way that we are trying to concrete that. So, in the case of Costa Rica, it is a healthcare system that has a component of social security, and the social insurance administered by the Social Security Costa Rican fund has become the only public sector vendor in healthcare services in the country. So the fragmentation and segmentation matters in Costa Rica are not there because it's not being fragmented. So it is a single social security system, and everyone gets the same set of services. And that has allowed us to have a unified system that, from our perspective, has made us get a better profit, if you will, to increase the effectiveness of the resources allocated to finance our activities. Also, without a doubt, this is a challenge. And just to close, as I was stating, it has been a challenge in previous years. And what is coming is an even bigger challenge. And then going back to the beginning, we will have to show the priorities and interests of society that should translate into public policies and state policies in order to achieve those levels of financing and efficacy that we need in our healthcare services. Thank you.
Thank you very much, Professor Gustavo. Now, my second question. In which way the pandemic and the COVID-19 pandemic has represented a challenge for financial sustainability in healthcare systems? I give you the word, Dr. Asa. I insist that I'm going to try to briefly answer in order to actually open a discussion space. First of all, as we all know, is that we have a simultaneous occurrence of healthcare expenses and a stop in economy. We were spending more in healthcare and we had less resources to spend due to the big impact that had and continue to have the pandemic in economy. We see a healthcare expense increase. In the beginning, it was very diverse. First, it was personal protection, the buying of drugs, oxygen, ventilators, red rays, X-rays. And in the next question, I'm going to give you the data that I have received in this regard. But first of all, I'm going to say that we had simultaneously a worldwide speculation and national speculation in resources. That is, we lived in a market where we saw a quickly increase of certain assets, and there were not enough production worldwide. And that also happened in the States or in the different countries. In Mexico, for example, at a certain time, we saw an important lack of personal protection equipment. We didn't have access to all the drugs and medications that we needed to have. And even we faced a scarcity of oxygen. And of course, there was not national production that could provide enough oxygen and X-ray equipment to everybody that was needing them. And of course, we didn't have sophisticated equipment to follow up all those patients that were ill and their condition. And how they were oxygenated later on. And see the necessary oxygen levels they were getting. And that will be my answer. Thank you very much. Now I give you the word, Dr. Gustavo. Thank you very much. Listening to Dr. Cristina Laura's words, in fact, the pandemic is a very precise phenomena. On one side, we see the financial masters and we see expenditures and revenues. But at a certain moment, we see the convergence of these points and we saw an increase in expenses, investment on infrastructure, and the increase of buying of certain equipment. At the same time, we had a drop in the economic recession and mobility restrictions, mainly in the first month of the pandemic. And it impacted in these two matters negatively and in these two dimensions. At that time, we cannot talk about sustainability per se because we need to see it at the mid and long term. But we need to see it in the availability of resources. And also it relates to the design of financing models and financial situations of financing companies and social security and insurance companies. In Costa Rica, there are two things. The financing level that exceeds 7.5% in the GDP allowed us to have a response rate that was satisfactory to what we were facing. And even with that, we required to increase the budget in certain items up to almost 5% in the national budget. And from my point of view, that is a relatively low impact. If we see the overall impact of the pandemic, because all the rest of ordinary services were available to all the people that were suffering from COVID-19. But it is in fact 5% increase in budget at that time. And there are some other activities, the vaccination, that has been directly financed by the state. That also for us has contributed a lot and has enabled us to have right now the third dose of vaccination financed by the state. Our work and what we do when we vaccinate people is to rescue some points. In the state, we have an extraordinary financing capacity for this type of activity. And The other thing, for example, the drop of revenues and the increase of expenses didn't impact us, but how to see available resources, because in the institutions, we allocate the budget in the beginning, and then and the health institutions always see the allocation of budgets. And at the end of a year, all the resources need to be spent. But in the Caja of Costa Rica, faced in 2016 a contingency, and we had an overplus, and that allows to have an initial financing budget, and that allows to quickly use it. And that was the way in which we faced the first months of COVID from the financial point of view. We use a contingency reserve that was to be used not for these kind of things, because we didn't imagine that we were going to have a COVID-19 pandemic or something of like that, but something of an earthquake or floods. Nevertheless, we enabled that reserve, and the institution and the government gave it to us, and that allows to finance the first spend expenses and all the what was needed to spend for COVID-19. There are some questions from the public. I'm going to mention the first question, and after answering it, I will follow with the second question from the public. The first is, good afternoon. Thank you for all your answers. In a financing Bismarckian model, is it convenient to do promotional prevention models? Because resources are scarce, and all the people, what they need is to be healed and to be treated. Thank you. I give you the floor, Dr. Asa. Dr. Asa, I think you have muted your mic. Yes, please unmute your mic, Dr. Asa. Okay, now, yes, very well, loud and clear. Okay, I was out of the presentation at a certain time. Okay, don't worry, doctor. I'm going to repeat the public question. It comes from Luis. It says, in a Bismarckian financing model, do you recommend to do promotion and prevention campaigns? Because all the resources are very scarce, and all the quotas need to be healed and need to be treated. Well, now, are you listening correctly to me? Yes, perfectly well, doctor. Go ahead. This question is a little bit, well, I think that the answer to this question is that we have to do both. And the Bismarckian model is for one part of the population, and in Costa Rica, that is a universal coverage. So there is no exclusion. So what we want to do with the healthcare system is to improve the healthcare conditions of population, not only give them access to healing treatments. But what I agree on is that there should be promotion, education on healthcare systems, in prevention systems, and also when population needs to have access to the treatment systems, we must provide them. That will be my answer. Now, Dr. Gustavo, you have the floor. Thank you very much. I think that the answer given by Dr. is quite wide. It doesn't have to do, as I think, in the model or in the primary care level. I think that the measures given were highly cost effective, and the models do not try to cure the persons, but to provide health, and that must be given at the first primary care level. And also we must provide a convergence. We must promote health and prevent diseases. But in certain cases where we are ill, the system must be capable to respond and give the hospital highly or low level complexity treatments in order to cure people. But I will say that beyond the financing model, in irrespective of being Bismarckian or not, I think that the primary care level will continue to be highly cost effective. Thank you. I have another question from the public. Diego asks, how can we provide sustainability in the healthcare systems when the population panorama says that there is an increasing evolution of chronic diseases in patients that require more cost and sustainable cost? Do we need to bet everything on the care systems, or do we need to combine with prevention and promotion? In which order are we going to answer? You go first, doctor. I think that the answer to this question is the same as the previous question. Today, more than ever, we need to bet everything for health education, promote healthy systems and prevention. And I agree with Dr. Gustava. We need to go further on beyond the health systems. We need to provide education and the sports activities and so forth. But here, I think we need to focus on the orientation because generally our healthcare systems, they are focusing very much on clinical scopes. We do not have a construction reactive response in order to give a twist to our normal activities. We need to go to better life conditions and to better population behaviors. I think there's no doubt about it. The problem is that we have faced many problems in order to actualize these new practices. And I will say that that deals, first of all, with the values prevailing in the society, because it seems that we cannot change the things if we do not change values. But yes, we need to start from there. And if we do not recognize the intrinsic value in the human being, then we will not be investing in the necessary life conditions to improve life dignity conditions. So I recognize that that is relatively abstract. But that goes hand by hand with the priorities of the government or the state government, and that it should decide, do we improve education or do we spend in high complex equipment to provide healthcare services that are highly expensive or more expensive. Thank you very much, Doctor. Now, Professor, you have the word. Thank you very much. I agree with what the doctor has said. In fact, we need to reflect, all the society needs to think, because social security will be more expensive next year, not only on the long-term treatments or the focusing of more resources to the less favored groups. So we need to see how we are going to finance when we see the OCDE programs where Mexico, Costa Rica has been included recently, and other countries. In this group of countries, Mexico and Costa Rica are in the less fiscal and contributive loads. Well, the governments need to see how do I allocate my resources to provide healthcare systems. Priority, we must be focused on chronic diseases and also implement strategies and bring the experiences of other countries and that, of course, require more finance. But here, we have not thought on how we are going to finance on the past diseases. We need to stop that and we need to think on the future, know how to provide and allocate more resources for the protection and social security in general in the future. And thank you very much, Professor. And we have more questions from the public. This is a question for Professor Picado. It comes from Jorge. Is there a relationship of investment recommended between healing activities and health preventive recommended practices? For how many healing practices we need to allocate preventive health practices? Well, this is a very interesting question. Needs a very accurate answer to give a balance. In Costa Rica, we have a 30% of investment in the primary care level against 30% in the hospital level. Well, I will say that every population, according to the particular conditions, must see and also on the complementary investment that focus more on health. The countries that can have access to good utility services and education, well, they can provide more resources to education, to families, and how to provide them more medications to provide better health lives. That has great value. So we need to provide more value to the primary care level and contributive and complementary measures that can highly increase the impact. And giving you a figure is difficult, but in the first primary care level, we need to invest between 30 and 40%. But that will depend on each country, but minimum 30%. That will be an excellent reference point. In relation to this, I think that we will need to specify what do we understand by investment for prevention and promotion, and what do we need for treatment and healing. Because what we generally use as an indicator when they say, oh, they invest very low in the promotion, education, and prevention. We need to specify more. Because if we see the large scope of what covers health prevention and promotion, we need to be precise to see what to include, because that does not only refers to the health budget. And I think that we need to remember that when we talk about education on prevention and promotion, that is more non-expensive than healing and treatment. So we need to clarify what we include in each expenditure, because if not, we will be just covering something that we are not completely specifying on what are we going to do in each investment. On the other hand, I totally agree that the fiscal load that Latin American countries in the majority have is very low. That means that we allocate resources in a regressive manner many times, because the countries that more earn and those that can contribute more, I think that they are contributing with a very low percentage of the revenue. And in the fiscal load, we are using a lot of the indirect tax revenues in relation to those people that receive less revenues. So there we need to see how to allocate in a better way the fiscal load on one hand, and need to see what do we want to include in the expenditure to improve the health life conditions. Definitely that will bring the investment on potable water. My answer goes there. Thank you, doctor. I will stop mentioning the public questions and I will resume with the questions of the program. So the third question in the same order will be, which strategies have worked very well and how have we overcome difficulties in relation to the sustainability during COVID-19 pandemic? Dr. Cristina, you have the floor. Have you listened to the question, Doctor? Dr. Cristina? Are you listening correctly now? Yes, perfectly well. I cannot give such a precise data in relation to what was the cause of the country for that, but I can give you some information in regards to what was the cost to the Mexican Institute of Social Security. What was the overall cost of the pandemic for the Mexican Institute? We do not know what is the global impact because we haven't yet received the data of the investment in vaccination. That was taken directly from a fund that existed and that was around 30 billion pesos, but it has not been estimated actually, and I don't have that data. The increase in total cost in the IMSS was 30,260,000,000 pesos. If you want to make a quick estimate in dollars, please divide it by 20. And the cost of all the inputs were 11,869,000,000 pesos. And the increase of staff expense was very big. To that increase in 207 billion pesos in training medical doctors was only the increase of 22 million. And that surprised us a lot because that meant that many people that were ill didn't have the right to receive a paid leave. Although very early, we succeeded in recognizing COVID as a working illness. And so the adaptation of units were of 3,366,000,000, while the expenditure of services in the private sector was of 600 million. And that was because we were not willing to provide the subrogated services in the private sector to treat COVID. So what we can see here is that the cost was effectively high. But the higher cost, and that talks very good about IMSS, was the expenditure on staff services in hiring personnel, because we hire more personnel to be able to keep up with what was or continued to be the curve for COVID cases. And also, what happened, and also is very relevant, and we need to remember, is that 30% of all the patients that IMSS received and treated was non insured population. The IMSS said, in this high priority condition of situation of catastrophe, national catastrophe, we included the rest of the population that was not insured. More or less, we insure 50% of the population, and then 5% is insured by other social security system, and the rest of the population is an open non-insured population. So there, what that meant is in these kind of situations, only the government is able to respond to it. Privately, it cannot be done. Well, the Social Security institutes can't support all this if they are sufficiently strong. And also, when the bodies or the three-party executors agree with implementation of palliative measures.
And so that's all what I wanted to answer, although it is like a little bit in the margin of what was asked. No, don't worry. Thank you very much for your very broad and comprehensive response. So we now give the floor to Professor Gustavo. Right. Thank you very much. So, about the strategies that have worked and how the challenges were overcome in this pandemic period, I think that there are several elements that have to do with current investment, but mainly with past investments. So the fact that we have a unique circuits network that is well integrated and that has geographical coverage, and also we have integral attention protecting over 4,000 people in populations, because we can say that we are all around the country, that allowed us to have the ability to respond to this pandemic that is higher than not having those conditions. So there are also some investments that were done in the past that had a very positive effect in this time. So there is a program for the institution so that children can and everyone can learn how to properly wash their hands, and the proper way to sneeze in open spaces, and also that allowed us to address contagion in a more advanced way. And also, in a way, the usage of masks was given naturally within the same culture. And then something else is that from the income perspective, it hit us real hard, just like it did for every institution and government. It didn't have the same impact, though, because we have a very uh, a large focus on medium and large enterprises. It did drop the markets, but it didn't put us in an awkward position. As I was stating before, we have a contingency plan that was about $150 million, so it's 5% of the yearly GDP, or the yearly budget for healthcare, and that helped us have a very quick response. And the strategy that was followed at the time was, of course, a careful and cautious strategy in other areas, and we tried to stay liquid in other essential need that we had. That's why we have reserves in assets, in liquid assets, so that we can invest them in our programs. And then lastly, we finalized some conditions so that the contributing associates could be kept, so that the companies could have a chance to maintain them insured at a lower cost. That of course allowed us to have those companies that had the chance to keep their essential employment. So that's why the labor market was kept, and that's how we got to have a very important impact and development. And of course, talking about the question, there is a series of strategies that have to do not just with what we did today, but everything that we've done in prior years, and also the development development and evolution that we've had over the past few decades and times. Thank you very much, Professor Gustavo. So now I will mention a comment by Claudio who wants to know your opinion about it. So I'm going to read it. It reads, I want to hear your comments regarding this. After the crisis caused by COVID-19, the labor market was deaccelerated. There was an increase in informality and unemployment. So about that, we have tried to adjust or change the financing scheme based on quotes by taxes on property. An immediate challenge is the period of transition and also understanding that it is essential to have a design for general taxes so that it can be progressive and sufficient. So we give the floor now to Dr. Asa. Yes, it is a very interesting question because what is being asked is, shouldn't we organize the healthcare system and based on taxes? So that's what lies at the bottom of this question. So the way that I see it is, should we continue to have a system, a healthcare system that is based on employment? And I think the answer to that is that the pandemic was a time when we were able to see that whenever there is a real need, simultaneous to a loss of jobs, anything that has to do with what we need, the only thing or the only way to solve that situation is the state, is through the state. So we should ask in all cases is how after that experience we can transition towards a universal healthcare system. As a comment on that situation, particularly in Costa Rica, I think it is very interesting. It's a very interesting example because Costa Rica had an almost universal social security program that it was based on that. So there are some demands, I'm not going to say, but they made them separate the financing of service lending and put them under different ways to regulate them. That is nothing other than the neoclassical model in economy. There should be a separation of function between financing and what has to do with the procedure administration. In Costa Rica, it was a very interesting case because since it was on an almost unique or single vendor or service lender, they did that universal coverage, which mean that, of course, they would change some things. They kept their essence, and actually, it is a universal system. So I think we should ask: is this, or this is the time to ask ourselves, don't we want a public and eventually free of charge system that is based on taxes? That means increasing taxes, of course, but the problem is, how are we going to do the progressive taxation? Because that's what we need. That's what it would take. And that would be my answer to this question. Thank you very much for your comprehensive answer. We give the floor now to Professor Gustavo. Well, I once again I agree with what the doctor said. I think in general terms, the trend is not to focus on the financing model in the labor market, but just moving towards a diversification. We have challenges such as having a higher financing level, but with a diverse source of financing. And then in that same term, they would decide if they are going to share all of financing through taxes and attributes, or if they stay in an intermediate stage where the labor market plays a role, but it also helps with other types of input from the fiscal perspective. But that's indeed what happens. And what I think is that the transformation of the labor market, also deepened by the pandemic, causes all of us who have a classical conception based on the contributions of the bosses and patrons and stuff, it's very hard to have that social security approach. Going to the extreme to finance that through the state, of course, and state resources for an institution like ours has to do with a trust issue where the governments need to comply with their commitment acquired, and also the loss of autonomy in the ability to make decisions. So the Costa Rican cashier is an autonomous in institution. We rarely go to the Congress or the state. And there are topics that have to do with financing, management, autonomy, and political matters. But just to close this intervention, for a model that moved from social security that is based on labor and to a universal one, the question is always there. Do we always open the door, or do we fully open the door in healthcare terms, and something that has nothing to do with the contributions? And so that would be um, my input for this question. Thank you. Thank you very much for your answer, Professor Gustavo. I will continue with our questions. So, lastly, I would like to ask from our system, how can we improve financial sustainability in healthcare systems at a longer term? So, we give the floor to Dr. Asa. Well, once again, I go back to what I said at the beginning of this conversation or discussion table. It has to do with the way and how we spend collective resources. It has to do with how we see the priorities and the needs of a society. So, what I would answer here is, because it's the bottom of the issue, it's what we've discussed around this table. So, what I would say is also giving us a chance with the pandemic is that there was this eruption of an element that took us out from our functioning routines in the healthcare systems. So I believe that this is an opportunity to deeply review how the institutions work in real times of waiting and the expenses by medical units, as well as considering the deficit of attention, whether it is because of the waiting times or other reasons. So we should actually also mention the question that we asked ourselves earlier. What is the model of attention, or how should we allocate the money for healthcare systems and different activities, and also improving the general life conditions, that everything that should be in the promotion and prevention campaigns, and how much in healing. And we should do that based on a more uh, in a more solid way, for a more solid diagnostic. So we need to have many sources of information in healthcare systems, but when we are comparing, it turns out that one source says one thing, another source says another thing, and then the third source says something else. So that is our moment, if you will, as a lot of people say. Crises are the moments to conceive a change. And I think that's exactly what we should do. But also, we should do a real assessment of the full cost of operation and the planning of the new needs for the service lending perspective. So, where should those service units be, and how much should you invest in them? And there, the trend, there's actually two trends when we see. On one side, the suburban areas of the big metropolises. They're growing so rapidly. And then generally, there is a lack of installation or facilities and programs. And it's actually a quite concerning one. We do not have access, or the population doesn't have enough access to healthcare services, including the small entrepreneurs. And it has to do with the new urban culture. So I believe that there is plenty of mobility there. So we should base on a system where families are adscribed to a medical unit. And that's not very efficient because they move rapidly. Families move rapidly. And also, families are de-articulated. And then the other pole that we have, which is where we do not have enough services, and that is in rural areas, particularly in Mexico, like in indigenous areas where we have very small communities. So we need to innovate there in order to be able to see how we are going to allow this population to have access on one side to what has to do with their life conditions, such as the access to healthcare systems, and also everything regarding their culture, because trying to extrapolate a model that is very westernized or occidentalized is not really successful in that sense. And also, we would need to see how we can make this population stronger in terms of healthcare units that are present in their housing areas where they live. So I would say that there is a need to reformulate what we are going to do and where from now on, and then how to turn any crisis into an opportunity, but also having a planning based in real facts and not on ideas that are there or have been there for like 40 to 50 years and doing healthcare and prevention promotion. And actually, we've been saying that since 40 years ago, and we haven't actually managed to do that. So, why don't we restate those kinds of things for ourselves? Thank you very much. Thank you very much, Dr. Asa, for your broad answers. And now we give the floor to Professor Gustavo. Thank you very much. So I would say that the first thing that I think is very important and quite not simple is that there is a progress from the conceptual perspective of what we understand as financial sustainability. And of course, there's no space for addressing what we should understand. But what is clear, actually, or should be clear, is that financial sustainability in healthcare systems is not a strictly financial topic, although it may sound controversial or contradictory. But also, there should be other stakeholders that could cause financial sustainability to healthcare systems without being an active part of the healthcare system. And actually, the concept of sustainability we associate with the financial aspect in healthcare systems and the institutions we integrate. We go through sustainability, social sustainability, fiscal sustainability, political sustainability, and we need to be legitimized by society as a system that is actually yielding the expected results. And actually, that has been a big secret and a key within the management of the pandemic in Costa Rica, where we have a very strong social activity and a very strong society for the system that we actually hold. And more specifically, on what's coming next, I reiterate that we need the financing, but also diversifying the different sources of financing. And there we need to establish what will be the mix between those financing sources, but they cannot be concentrated into the traditional healthcare system, but in social contributions by the different or as per the different characteristics by the labor market. And also the systems, the healthcare system should have a financing model that has an anti-cyclic component, and they should have enough flexibility to face extreme situations such as the pandemics that we didn't have for 100 years. And a lot of us, we didn't understand uh, that it was a real possibility, but the system should respond in an adequate manner, and it should not involve less quality or lower quality services than the financing of the first level of attention in a different way. And I think that an important topic we should consider is that we should mobilize resources for specialized service level at this level. So a lot of the professionals have more activities or more specialization, more clinics, more hospitals, but we need to make an effort to move resources to that first level of attention. Then we need to increase the quality and effectiveness of the expenses. Without a doubt, we do have international studies and reports that say that over 40 to 50% what we spend in healthcare is not enough, and there is enough evidence that we could use patents or a generic, or the rates of infraction by C sections are like 60% of the inefficient expenses because of the implications that they have for the mother and the child, and how chronicle some diseases could be when they're produced in that stage. So also we should innovate in the service healthcare service providing for society, especially for the new conditions. And the more effective we are, the more we will be able to achieve or move towards sustainability, because we don't say that it's a certain thing, but it moves and we move towards it. And then lastly, we should see the way, but there are ways, is that we should emphasize the incentives, self-management and healthcare uh, system through the same people. So I don't see a possibility of a healthcare system to be sustainable if people are not aware and really take care of themselves to improve their health conditions. So at the end of the day, sustainability is a big challenge that has a strong vision on the financial aspects, but it is also under the umbrella of what we can do at a future. Thank you very much for answering our program questions. Now I will continue with one last question by our audience. So Daniel says, you have very interesting answers. So do you believe that digital health can potentialize financial sustainability for social security institutions? And if so, how would that happen? Dr. Asa, we give you the floor. Well, that question has a lot of possibilities, a lot of corners to approach. And I believe that one of the things that we can see from the pandemic and in the specific experience that we had at the Mexican Institute of Social Security was to try to channel a large part of those who were not actually very sick to to their attention in smaller healthcare centers. And we gave a tick on what they had if the patient needed. But the novelty was that there was a connection for them. They would connect daily with first level healthcare workers, so that they could know what was their progress. And actually, within these centers, we did remote or online consultation, and it was not for everyone, but it was a significant amount. So we managed to break with many of the topics, like the fact that the patient wanted to be directly at the doctor's office. That happened in a very successful experience, but I've had other experiences with digital or online health that have been very negative. For example, there is a very interesting and important investment in digital healthcare to do more complex consultations through digital platforms, with consultations within the experts and the first care workers. That oftentimes, if it's not done correctly and well structurally, it will not yield very good results. Why? Because essentially, especially where you need to do that consultation, they do not have the proper conditions for you to do them. So there's no connection, no internet connection. There, there's no way to connect to the internet. So another thing that has worked, and of course, it would be a very important topic, and I would like to underline, as long as we guarantee patients that the patient's personal information belongs to the digital clinical files for the patient. So we have managed that. So there is legislation about that, but that doesn't mean that it's not implemented. So what has been seen is that it's relatively easy to do that at the first uh, level. So we need to check out on the connection possibilities, and it's actually very complicated to do that at more complex contexts, because there are two topics that are complicated. Actually, one of them is that one of the things that would be avoided if we have a clinical file is not to repeat everything that comes from the first technology, but you know, it has like a very, very heavy weight. So it's very difficult to get access or enough access to it. And then the other topic, of course, is that although we have rules for protection, for the protection of patient information, we have seen in other countries that it's relatively easy to break that protection or to breach that protection. So I believe that without a doubt, we will see or look forward into a very important development. However, that doesn't mean that we are going to need less healthcare workers that are directly involved in the promotion of, for example, habits or healthy habits. And what Dr. Gustavo said, the proper incentives for healthcare or self care. But from what I see, it will be an instrument that will help us move forward, but it will not substitute, like in some cases it has been said, that it will substitute the media, an algorithm, and that's it. We are on the other side with what we have to do with the patient. And it also doesn't substitute nurses and so on and so forth in terms of the workers. So that would be my answer. Thank you very much, doctor. We give the floor to Professor Gustavo.
I again agree with the doctor. I think she said it very clearly. Our experience is that that type of services can help and complement the traditional services for certain types of care, but not to substitute ordinary services. In Costa Rica, we have a unique health digital system that has been a very powerful tool to face the pandemic consequences. But also, Costa Rica and the rest of the countries will have to face the backwardness of the long waiting lists that were under certain relative control, but we are having a list of more than 400 days. And there are included non-COVID patients, not only contagiated of COVID, but also suffering from chronic diseases. And from there, we see the relevance of the healthcare personnel as contact person and direct contact person with the patients. And to give you a data, we have 1,700 different care segments for the integral coverage. And the board took the agreement of creating 340 more equipment to reform and enlarge the reform initiated in 1940s. And so we will be covering that with that equipment more than 4,000 people. So these technical primary care staff that go to houses and spread practices of good health systems to the families directly will be increased. And the future of care will be on the hands of the staff that continue to be skilled on these and that can be supplemented by the virtual digital services or based on certain technologies. Thank you very much. Well, once again, I want to thank both the speakers for having participated in the webinar, and I also thank the public for their questions. In order to wrap up the conversation, I want to give the floor to Dr. Gwendolyn Bravo Zurita, that has a PhD in economy with honorific causa and graduated from the UNAM. Her investigation focuses on digital agenda and IT and information technologies and communication on the Latin American and the Caribbean region, as well as the macro and microeconomic variables and financing, monetary policies, credit and financing in Latin America and the Caribbean region. He was a coordinator of administrative system and causa system in the CES and coordinator now of the Inter-American Center of Social Security Studies. And good afternoon for me. It's a great honor and pleasure to listen to you. So I thank you once again to have been accepted the invitation given for this conversation space. I want not to summarize, but to open this debate that has very relevant topics and to be extended. And the institutions of social security and healthcare systems have these topics in their agendas and also the CS. So as our guest speakers have said, the pandemic has represented a great challenge for all the systems in general and economic systems specifically. For the healthcare systems, well, we're surprised by all these, and all these health systems have been exposed and they have faced the main challenges. And here we have seen what has been reflected by the cost, all the elements that intervene in long-term sustainability. But in the disruption that has caused the pandemic, we have to emphasize all the cases that have been mentioned. The IMSS, the Costa Rica, how these institutions face this main challenge by increasing enormously the expenditure. And also, in talking about the IMSS, how we open the system to even insert the non-insured people to enable them to have a healthcare provision and to face the COVID pandemic. The increase in expenditure, of course, in long term and mean term, will represent a great challenge. And also, the speakers have talked about supply and demand, the increase of costs, the impacts in the economic sector, and the political sector and social sector. So there, we need to open the doors to sustainability because it includes more financial methods and how to reinvent and include other stakeholders and not only healthcare systems because it goes beyond the doors of the health systems. So this debate opens the inclusion of several topics to include the challenges, of, for example, of seeing in the region, and that is a highly heterogeneous region, uh, the challenge to face many new elements. And because the speakers have talked of taking decisions based on the specific conditions of each country and focus on the government that will have to take their important role in the taking decision role. So thank you for all your participations. And now I give back the floor to Dr. Martinel. And thank you very much. And I would like to say bye-bye, but not without thanking the speakers. And I thank the CS team for enabling all us, this space, and the public in general for your questions. And also, Dr. Daisy Corrale, I give you the floor. Thank you all for participating in this important space of conversation. This is part of continuous education activities in the seeds. We have the academic program available in our webpage. And I also want to tell you that we have a digital strategy that are the microsites. In each of them is generated from each Social Security Inter-American Center a lot of accumulation of information to be updated. So this morning, we have received a lot of knowledge. We have talked largely uh, and we have listened through questions on the strategy, sustainability of healthcare systems. But I see that there is something on the table. Dr. Asa said that we need a solid diagnosis to plan. This is very important because we have now a lot of experience to know which are the preventive measures that can really impact and which other assistance measures can also contribute to enhance promotion and prevention measures. So, as Doctor said, there is something very important that she mentioned, that the crisis can be seen as a scenario of opportunities. And yes, it is like that. Because in that space of conversation, she said that we need to be updated because in the care model, we carry a diagnosis of 20 more years. So this is an opportunity to make a cutoff, to evaluate and see all the theoretical proposals that we have received from international bodies in relation to the integral care model and validate them because now we know what is profitable and can be used in the system and what means all the health coverage that, for example, that we have in Papa Nicolau technique to prevent cervix cancer and to be able to achieve the sustainability in certain items. And that will depend on the model, on the conclusions that, as we have said, they depend on the values of the country, what they want to achieve and how they are going to finance them. In that sense, we need to differentiate the great number of groups of expertise. In health in general, we talk in expenditure in the first years. And now we're talking of investment because in the area of promotion and prevention, if we see it as an expenditure, we will prevent the development of programs that in middle and long term can impact tremendously the finance of Social Security. A topic that in this space of conversation emerged and that we have discussed in many debates of the conference is the financing channels. Yes, of course, during the crisis, how we saw the increase of expenditure versus the decrease of revenues. That brought us a lot of lessons. As we saw how we decreased the working space, the social security was weakened because this is a primary care level. And so we need to think once again on some progressive taxes. I personally think that many of the taxes that currently exist in the system can be reoriented, mainly when they are related with health. So, for example, in the commerce, we need to promote the non-healthy practice. Then we need to impose a tax that's segregated to many sectors and in health, as we have implemented in tobacco and liquor beverage. And in the financing, well, we need to plan how to finance in relation to the protective health elements. How is the potable water quality, the housing level, because that all will increase a holistic health system and will provide it as a human right. So I invite you to have a constant communication from the Inter-American Conference. We will have a lot of working spaces. We will be participating and inviting you. And you can also join us. And I recommend you to be reading our webpage to all the academic activities in the investigation and extension activities, because as soon as you enter into our webpage, you are registered as our guests to all our activities. Dr. Asa, I thank you very much for your valuable time. And Dr. Gustavo, as always, we thank you very much for your participation and mainly for all the opportunities of learning and all the lessons that we can provide in the Americas. Thank you very much.